here in view of patient privacy. So he saw us on June year 1. His viral titers were very high. Otherwise, he was well. Child-Pugh score of 5, alpha-fetoprotein 9.9, and we started him on entecavir because he was never treated before, and we need to start the treatment in order to treat the HCC. So this is the CT scan. At the time he turned up to see us, he has a 5.5 cm solitary HCC in segment 7, as you can see here. Unfortunately, the tumor, as you can see on the picture on the right-hand side, has really invaded the right hepatic vein and is indenting the IVC. So obviously, this is no longer early HCC. This is, in fact, BCLCC with invasion of hepatic vein. So he was discussed and we worked him up. So at this juncture, maybe I'd like to hear from the audience, what do you think would be appropriate management for this patient? Of course, if we do surgery, it has to be an extended right because of the invasion of the IVC, and we have to take a cuff of the IVC with reconstruction, which is a very big thing, and potentially not curative because of the vascular invasion into the IVC. Well, we can do RFA. Tumor is a bit big, or there's vascular invasion, transarterial tumor embolization, Y90. Of course, today we have immunotherapy and also TKI. Any opinions from anybody in the audience about what would they consider doing?
Well, if I may be allowed, I would do a SBRT or SIRT as a first choice. You can also do, being a surgeon, you can do the surgical part. But since this is a patient where the vein has already been invaded, and also I would like to know whether there is ICG was done and what was the pivotal in this patient.
Right. Yes, we have ICG data and so on, but at the moment the patient is Charles A, so we expect that to be good. The problem with the surgery is not that it's technically not doable. What we will do when we operate on patients with invasion of the right hepatic vein, like in this manner, other than the fact that you may have to do a cuff resection of the IVC, what we would not want to see is that 6 weeks down the road, we see lung metastasis, because essentially the surgery itself will disseminate the tumor if the tumor is not already disseminated. So these were the considerations we had at the National Cancer Center in Singapore. SBRT is, I think, a useful technique, except that because the tumor is already almost entering the IVC, it's very close to the heart. And our radiation oncologists are very reluctant to irradiate anyway, very close to the heart. But anyway, we are center that uses a lot of radiation in the form of Y90. And Y90 is, of course, known to be useful for vascular invasion. So in this patient, we chose to downstage a patient with Y90 with a view that in the future, if the tumor regresses away from the vein, we can resect the patient with good oncological outcomes and long survival. So he underwent Y90 via the segment 7 artery with a dose of 0.62, but very important to see that the mean radiation dose of the implanted tumor is very high, is 199. And I will come back to this point a bit later in my discussion. So this patient was treated, and we were very happy with the delivery of the radiation, right where it is, with very little collateral delivery to the rest of the liver. And October year 1, so that was July, so this was 4 months later. You can see the alpha-fetoprotein coming down quite nicely. And also the tumor itself has responded quite remarkably from 5.5 to 2.5. The right hepatic vein does not seem to be invaded anymore. And we don't see, to our happiness, we don't see any evidence of lung metastases, because once they invade the IVC or the hepatic vein, they tend to appear in the lung pretty fast. We don't see lung mets. So we are very happy with the results 4 months later. And the next month, we repeated that. It has regressed a little bit more, but it is still abutting the hepatic vein. And we think that the patient will continue to regress. So we stayed our hand. And indeed, the next year, in February year 2, and this is, of course, about 8 months after the patient was diagnosed, it has regressed to 1.8 cm. So we discussed surgery with the family. We don't think we need to do extended right hemihepatectomy anymore. Our right hemihepatectomy will do. Of course, before that, we'll do a volumetry assessment and do the ICG. The other alternative is do an RFA because our radiologists feel that a percutaneous RFA is going to be very challenging in view of the close proximity to the IVC. But the patient wanted to wait because they saw that the tumor is regressing. They requested for a wait of 2 months later to look at whether there's any more regression. And April the next year, so this is 10 months later, indeed it has regressed a little bit more with good response. So we think this patient should be time to do surgical resection because it's curative. And in our experience, when the tumor regresses like that, surgical resection usually has very good outcomes. ICG was very good. ICG at 15 minutes was 16%, which is suitable for a right hemihepatectomy. And as you can see, the alpha-fetoprotein has now normalized. So this was suggested to the family, but here you can see the tumor that has regressed. And this is the volumetry that we did, which shows that with the right hemihepatectomy, the future liver remnant will be very good at 47.2%. So this surgery is going to be very safe. So we persuaded the family that it is time to take advantage of this regression and really go for a cure. Of course, patients have patient autonomy, especially in Singapore. Patients can have their own ideas sometimes. But for you, would you agree that this is a good time to do surgical resection, or you think that we should do some other thing at this moment? RFA or Dr. Shina? Shina, what do you think?
Yeah, yes. I don't think the RFA is very challenging. It's very near to the to the infravena cover, but we usually perform ablations without hesitation, even
Yeah.
in this case. So
So you do
I
a
don't think,
percutaneous.
yeah,
I see.
percutaneous ablation would be okay.
Be okay.
Yeah.
Any other opinions from anybody before I proceed?
Laparoscopic surgery.
Hi, laparoscopic surgery. That means surgery, like in other words. That means surgical resection, is it?
Robotic, whatever.
Oh, robotic. Okay. But basically, it's a surgical resection, which is quite different from RAFA, of course, yeah. So a patient requested another repeat scan. It's even gone even smaller. So we offered again. Right hemi, but our radiologist is not as confident as Dr. Shina, so they wanted to do open RFA. Interestingly, the patient preferred RFA. So RFA was done for segment 7 lesion, very small lesion, not very challenging, I think. So the patient after that was followed up very closely. So every half a year we'll scan the patient, and the next event occurred at year 6. So year 6 is more than 5 years after the RFA. So the patient now has a new lesion. Later we'll go back to this to discuss the concept of what is recurrence and what is de novo tumor. But anyway, this new 1.5 cm non-hypervascular hypotenuse lesion in segment 6 is another segment, not the same segment. Doesn't look like an HCC because it doesn't really enhance and wash out. And because it was not clear, we thought we should do an MRI, and the liver function test was normal. Alpha-fetoprotein was also normal. So we did a MRI, and this suggests either an abscess or a cholangiocarcinoma. And because of that, histological diagnosis is suggested. The previously RF8 lesion in segment 7 showed no evidence of HCC recurrence. So this was the MRCP. The MRCP shows 1.5 cm lesion, segment 6 this time. The previously RF8 lesion was actually no longer viable. So this is the biopsy report. This is positive for polydifferentiated carcinoma, comments the feature favors cholangiocarcinoma. So now the patient has cholangiocarcinoma, very small. How would you manage this patient? In the same lobe of the liver, but it's a different segment 6. Any suggestions from anyone?
Routinely do the laparoscopic nowadays quite often.
So in other words, surgery, yeah. I mean, laparoscopic
Yes.
surgery, robotic surgery, they're all surgery. So surgery is one modality. Dr. Shah,
We perform microwave ablation.
microwave ablation.
Microwave ablation. Even if the
This is a
this is a
sclerosing
cranio.
cancer.
Huh?
Better watch out.
Pardon?
Sclerotic cancer.
Yeah.
So better watch out. Not encapsulated hepatocellular carcinoma.
Yeah, but even if it's the craniocellular carcinoma or liver metastasis, we can ablate
You can do it.
with yeah, safety
we'll
with
see.
safety margin. We can get the so local cure. So we
Yes,
right.
but we'll see.
So, Dr. Omata, I don't see your camera, but I can hear your voice. So if you were to do surgery, whether robotic or laparoscopic, would you do a right hemi or would you just do segment 6 and 7?
Well, as soon as possible, if it's possible, expand it. I ask the surgeon to, to try to include larger mass, if possible, if the liver function maintains. Because cholangiocellular carcinoma is very difficult to see the boundaries of the tumor existence. So I think try to make more wide, the cutout the specimens as possible.
So would you think it's also a good idea to resect the previously RF8 HCC, which has shown no evidence?
That's a hepatocellular carcinoma, the previous
So
one.
you don't think you need to resect that, just the cholangiocarcinoma with the white margin, is it?
I have cases, in the same patients, one time had hepatocellular carcinoma, later on got a sclerosing cholangiocellular carcinoma, and then the prognosis is not that good. I think
Yeah.
it recurs. Yes.
This actually boils down to the
And then how's the CEA or CA99?
CEA, CA99 were both not elevated.
But very touchy elevation you notice sometimes, like even though 19 step up to 22 and then 25 and 27, not like 100. So that's a steady kind of the rise can be seen. Even though AFP, L3, DCP not elevated at all, but there is a kind of the very gradual but steady CEA, CA99 rising. We just
The other thing that this case reminds us of is that the progenitor cells of both cholangiocarcinoma and HCC are actually the same. So from the progenitor cell, they can go to either HCC or cholangiocarcinoma.
You don't have a histology here.
Yeah, we have histology here as a cholangiocarcinoma. Yeah.
Yeah, but you don't have the actual photomicrographs here.
Oh, sorry, I did not provide that to you.
Okay.
Yeah.
But do we have PET scan be ahead of these at the very beginnings or at any stage, especially with the C11 acetate test?
We don't routinely use the PET in the National Cancer Center. I know it's very widely used in Hong Kong, the C11 acetate. So we tend to follow APASL guidelines with either MR or CT. So we don't normally use PET scan for that yet. So we don't have much experience with the C11 acetate.
Okay, and the second question is, you have liver transplantation available for these patients?
For him, the waiting time will be very long because he is Charles-Pills A.
Mhm.
In the beginning, with the invasion of the hepatic vein, he will not be eligible as a candidate because
Right.
vascular invasion usually precludes them.
Right.
Otherwise, we have a cadaveric program. We also have a living-related program. So of course, waiting time for one is longer than the waiting time for other. But for him, because of the vascular invasion, in fact, he will not be a candidate in that sense. Yeah.
This stage, I mean, when the patient starts to have this cholangiocarcinoma, right?
Yes, as a cholangiocarcinoma, because he's non-cirrhotic, his waiting time for a transplant will be very, very low. Because it's very small, it can be resected and so on. And he's Charles-Pills A. The waiting time is probably, he probably will not get the chances of getting a liver will be not so high, I would say. Yeah. Or very low.
It's a very interesting case because then you have a double tumor.
Mm.
and then cholangiocarcinoma.
Mm.
I just it's difficult. It's difficult the situations. And Professor Mata or the others, you encounter such double tumors.
Yeah, I do.
It's
Yes.
some, right? And I think the question is very important about the CA 19.9 and whether this is really a rising trend or even within normal range. That would alert us at any stage. And in Hong Kong, as you said, we will do the PET and we will be able to pick up a hepatocellular carcinomas or a mixed type or cholangiocarcinoma separately.
So, Dr. Shinai, you will RFA.
Yes, not RFA, but microwave ablation, because
microwave
we can
ablation.
get a larger ablation volume in
Yeah.
microwave ablation. We use yeah.
Can I make a comment, sir?
Sure.
Yes,
Hello.
please.
Yeah. This is Dr. Deepti from New Delhi. So for such tumor, I will go for a PET scan to rule out any different metastasis because the histopathology is cholangiocarcinoma, and I think with 1.5 centimeter tumor, we can easily target the tumor with radiation as well. SBRT is an option for such patients.
Mm. Okay, so we hear three opinions here: surgical resection, RFA, SBRT. Okay.
Yes.
So let's see what happened to this patient, because this is the dynamics with the patient and so on. So we offered surgical resection or RFA because surgical resection for cholangiocarcinoma is still standard of care, but the tumor being so small, RFA will also be acceptable. The patient was not keen for surgery. In fact, this is the ongoing background because the patient is really not keen for surgery. And because of that, we went for CT-guided radiofrequency ablation of the segment 6 cholangiocarcinoma in May of year 6. And then, of course, this is 6 years after the first RFA. So the patient continues to be followed up 6 monthly and so on with scans. Interestingly, in February year 7, the alpha fetoprotein went up, as you can see from here. When we did the RFA for the cholangiocarcinoma, both the CA99 as well as the CEA and also the alpha fetoprotein were all normal at the time. So this is likely to be another source. And because of that, we did an MRCP. And this MRCP was very interesting. So this is year 7 from the RFA. At the one of the corners of the RFA site, we found a 2.4 cm tumor at the site of the first RFA. But here there is a very good margin between the new tumor and the right hepatic vein. There's no invasion of the vein. So this is what happens now, 2.4 cm. As you can see, this is the tumor, and then this is the coronal view of that. So now, interestingly, the new HCC has come about. Of course, we can discuss whether this is a real recurrence or de novo tumor because of the background hepatitis B, because it's 7 years out. But at the end of the day, we need to manage this patient. So these are some of the options available. So the patient had RFA done for HCC invading, had Y90 done for HCC invading the right hepatic vein 7 years ago, when that regressed, treated with RFA at the patient's request, not surgery. Subsequently, at year 6, developed a small cholangiocarcinoma that seems to have been totally ablated. And now in year 7, has a new HCC at the site of the RFA. So what are the considerations that you will want to do for this patient? Maybe I can hear from the views of the rest of the experts here.
Of course, we perform microwave ablation for the this third tumor.
Yeah, thank you for your any other alternatives? The surgeons here or George? Or
Yeah, this is pretty classical. That's why I asked for transplant at some stage, earlier stage, because the recurrence is always a big concern. After all, the patients already have the first hepatocellular carcinoma, and then well, cholangiocarcinoma, and we feel
think
that
he's done remarkably well because vascular invasion, hepatic vein, median survival is usually less than 6 months.
yes, it's good. You are doing a marvelous job. But then now we are facing HCC.
Long-term sequelae.
Really, the liver is no good. And in fact, well, I agree with Sheena. It's, RFA is an option. In our place, we will do sometimes an open RFA too. I'm not sure whether Sheena would like to comment. How would you?
But Dr. Sheena, the right liver obviously has a field change because you can see that the cholangio has come about and so on. You don't think it's appropriate, although the tumor is quite small, now that he has got the third tumor in the right lobe, you don't think it's appropriate to resect the right liver?
But
Something
maybe the patient would not, or patient family would not like to undergo
Yeah,
such
patient family refuse, but would you
So-
recommend resection?
Of
Would
course,
you-
the resection is, yeah, in the
Because Dr. Lau is actually is still recommending transplant because the liver is suspicious, is a field change.
Well, transplant is still the best options. Even at the earlier stage. And with
Although the first time round with the vascular invasion, he wouldn't have been given a liver. Now 7 years down, no vascular invasion, 3 lesions.
survival. Even if they have a vascular invasions, you have a very long survival with all the managements incurred on these patients. Is already a marvelous
Yeah,
job.
I agree. It's a reasonable to suggest transplant. But Dr. Shinai will still prefer microwave ablation, right?
Yeah, yes.
Any surgeons want to do a right hemi? Dr. Amata, about you?
I'm not a surgeon, but since I came here, there is a very good surgeon who does laparoscopic. So even the age 83, I recommend the surgery.
So
It's
for
not
this
really a
patient,
surgery.
would you
It's
recommend?
almost near to the RFA in terms of the invasiveness.
So anyway, the patient dynamics do come in, and patients do have their ICG was actually very, very good. So we persuaded the patient. So initially, patient agreed for resection, but later on, at the last minute, he changed his mind. He want RFA again. So we did RFA, and the tumor was actually biopsied. But interestingly, the histology did not show that it was malignant, although we are quite sure from the MRI this was HCC.
Oh,
What happens after this was more interesting. So of course, the biopsy can also be a sampling error, considering the patient's the tumor was at the site of the old RFA site. But anyway, patient said there, I told you, luckily I have RFA rather than removing my right liver.
May I ask with some pathological aspects there is no elevation of CA or CA19
So
at all.
CA19, they're both flat. The only thing that went up very significantly
All
was
through.
yeah.
4 years, nothing
Yeah.
happened. And they were saying there is a cholangiocellular carcinoma at one time.
Yeah.
Maybe it's not the cholangiocellular carcinoma, maybe hepatocellular carcinoma there.
But that one was biopsy proven.
Yeah, but
On the imaging, it is also not consistent with HCC because there's no arterial enhancement and washout. So doesn't fulfill the APASL criteria. And on the biopsy, it was deemed to be a cholangiocarcinoma rather than HCC. There's a question here from Dr. Teh Kung Kang. Any underlying hepatic disease? Yes, certainly. The patient actually had hepatitis B. It is a liver that is hepatitis B, although there was minimal cirrhosis. Yeah. So anyway, let me just take this off first. Okay. So patient, let me see how to get rid of this picture. This thing is okay. So at first he agreed for resection, but they went for RFA. And of course, during the RFA, we took the opportunity to take a biopsy. Biopsy doesn't show anything. It could be a sampling error. Because what happens is that the following that, year 7 now, we did a CT scan and we found anterior and posterior sectorial branch of the portal vein with tumor thrombus. Alpha fetoprotein went up even higher. So the thrombus was already noted during the RFA, but they did a contrast enhanced ultrasound, and they thought it was not enhancing. And because of that, we wanted to investigate further and be more sure. So a PET scan was done. So you can see that this is a very different animal from the first tumor. Now the patient had multifocal tumor. So the PET, so George, we use PET only in instances like that. We rarely use it upfront, maybe because we don't use it a lot, that's why. But in cases like that, we'll definitely use, because now we have a diagnostic quandary. So we can see multifocal HCC, extensive thrombus. There's new thrombus at the portal vein. So this biology of this new HCC seems a little bit different from the old one, which was a solitary and quiescent. So clearly he has a lot of problems now. So this is a bilobar multifocal tumor with extensive thrombus. So we don't think the Y90 is useful for this patient because there'll be a lot of shunting to the lung and so on. So in July year 7, we decided that this is time for systemic therapy. So patient was started with atezolizumab and bevacizumab, and a following scan a few months later showed that it was actually progressing on atezolbev, and alpha fetoprotein was even higher. So clearly atezolizumab and bevacizumab is not useful for this patient, so he was switched to lenvatinib. He developed right hydrothorax with likely secondary to portal, because the tumor has now invaded the portal vein, so the portal hypertension is very significant, also presented with ascites. So because he was still progressing, we switched him to Xeloda and thalidomide. This is a therapy that the NCC published many years ago, has some utility for patients, usually now used as a third line. And by March the year 8, clearly we think the patient should be best supportive care now because patient has progressed a lot. And in April, in year 8, the patient passed away. So interestingly, diagnosed in June year 1 with HCC with invasion of the right hepatic vein, overall has 3 tumors, but eventually survived 7 years and passed away. So this is an interesting case, and I think there are a few discussion points and take-home messages. I think the first is the advent of ablative radioembolization. And this one I'll discuss a bit more because it's a very recent development over COVID actually, last 3 or 4 years, and its impact on HCC. And secondly, I would like to touch briefly on the definition of recurrence of HCC. When do we call HCC a recurrence, and when do we think it's a de novo tumor on the background of hepatitis B or cirrhosis? And of course, as I've touched earlier a bit, we recognize that the common progenitor cell for HCC and cholangiocarcinoma are actually the same. And I think if both happen, it's usually a very significant field change. And also, I want to touch on the pivotal role of surgical resection in the management of HCC. I think firstly, I think most of you or all of you are familiar with Y90. And of course, a lot of the pioneering work was done by the late Professor Joseph Lau, who passed away a few months ago. And when he did the pioneering work about 40 years ago, the technology was not as good. And he recommended a dose of at least 120 grays. This addition per tumor volume. So this was what people has been using for many years. And of course, about 10 years ago, the catheters become much better. And because the catheters become much better, a lot of interventional radiologists do super selective cannulation and only target that quinoid segment. So that was about and in 2021, which is in recent memory, what was proven on explanted patients was that if they use super selective targeting, and then for the segment itself, they give a super high dose. And then, of course, the patient is subsequently transplanted. Then they show that there was actually total necrosis. And because of that, there's a move by interventional radiologists and nuclear medicine doctors the last few years to move to much, much higher doses than that originally recommended by the late Professor Joseph Lau. So there are, as you know, two forms of Y90, TheraSphere and Bayesian microsphere. And recently, new studies have shown that one is actually better than the other in terms of regression. And as I said, all these papers are within the last 4 years, where most of us were busy with COVID and so on, and not all of us might have come across them. But what I've done today is I've summarized some of the data. So the legacy study, of course, was what led to the FDA to approve Y90. And here you can see that the dose they used was very, very high compared to Professor Joseph Lau's recommendation, 400. The median overall survival was 57.9 months. Objective response rate was very high. So this is a Villabos study, a very interesting study. He used a resin and glass, and resin and glass essentially has different doses. He hasn't reported the median OS, but the response to the resin was extremely high at 95%. This is best overall response rate. The dosisphere was a randomized controlled trial using two doses, Professor Joseph Lau's standard dose and a much higher dose of 205. And you can see the difference in the median OS and also the difference in the objective response rate. And this was using resin. So using glass, we can see a very good best objective response rate. And from our hospital, and this is IMPRESS with liver cancer, we have seen that if you look at our patients treated with less than 150 or more than 150, there's a significant difference in survival. So currently, ablative Y90 is being practiced by most nuclear medicine physicians and IR. And this looks at that. This is using resin, and this is the response rate of 95. Using glass, you can see that with increasing dose of radiation, it increases, but some seems to plateau around 400 because 700 doesn't seem better. And here we look at survival. So this is glass on top, dosisphere with glass. 120 grays, 10.7, 205, 24, and 410, 57. This is resin, less than 150, 17.5 months, and more than 150, 32 months. So I think this is the new science that we are looking at. The radiation dose should be increased, and the patient should be doing better. The patient that we had actually had a dose of about 200, which may explain why he responded so well. The second thing I want to discuss is, of course, for this patient, between the first tumor and the second tumor, it was more than 5 years. In the world of oncology, 5-year survival is usually our yardstick. If a patient can make it to 5 years, we'll say that, well, the patient has a very good chance of cure. So 5-year survival is important. So if we resect for HCC, for early HCC within the Milan criteria, what kind of 5-year overall survival do we expect? So we look at these more than 4,000 patients, and we found that the 5-year overall survival for patients within the Milan criteria, which is, as you know, the criteria for transplantation in some places, the 5-year overall survival is 67%. And 67% is interesting because it crosses the philosophical 50% overall survival at 5 years. We will say that if your therapy can give you more than 50% overall survival at 5 years, we consider this potentially curative because there's more than half a chance that you'll be alive. So it means that conceptually, resection within the Milan criteria is conceptually curative. But in the patient that we have, he actually passed 5 years. He passed 5 years and then he developed another tumor. For recurrence of tumors following treatment with curative intent, of course, this one is based on surgical resection. There's actually a bimodal pattern of recurrence. The first pattern of recurrence is usually within the first year, at about 12 months. And this is usually believed to be from micrometastasis. So for example, if we had resected the patient with the vascular invasion, we are quite sure that the recurrence will be within this period. There is, of course, a second peak at about 4 to 5 years, and most people will accept that this is de novo tumor arising from a background of liver cirrhosis or chronic hepatitis. But the oncology outcomes are actually very different. If you look at the chart on my right-hand side, the early recurrence patients do very, very poorly. The late recurrence patients do much, much better. And this is generally true across the whole field of surgical oncology, of course, including breast, colorectal, where late recurrence is always better than early recurrence. In this case, the patient recurred after 6 years, and the biology of the tumor appears quite different. So it is possible that the so-called recurrence may be a de novo tumor. And when we treat these late recurrences, the biology may be quite different from the original tumor. So if you look at the timeline of this patient, it is quite interesting. June 1st year, diagnosed with 5.5 cm. The size is not the problem. The problem is the invasion of the right hepatic vein. Of course, we know that we resect the patient, the overall survival will be quite low. Most series will be less than a year because they recur very fast. Because of that, we treated with Y90 at a very, very high dose, and it regressed significantly. Patient has declined surgery, so RFA was done, and this tumor regressed. 6 years later, the patient developed a histologically proven cholangiocarcinoma in segment 6 of the liver, and this was treated with the RFA. But by now, I think we realized that this patient has significant field change. You know, the hepatitis B has affected the liver in that manner. And in year 7, developed multifocal HCC with PVT. Started on systemic therapy. The multifocal tumor first appeared on the right lobe. Subsequently, we see it in the right and left lobe as well. So again, I want to bring you back to one of my first questions. If the patient had surgical resection, for example, after the tumor first regressed with the Y90, perhaps all of these other things may or may not have happened, but we won't know because there's still the left lobe. But all the tumors here first appeared on the right lobe. Of course, in the final one, it also finally become multifocal. So surgical resection has some merit to it in the sense that it removes, and of course, like Professor Lau will say, well, transplantation will be even better for this patient. So anyway, I think this is my summary. I'm happy to hear from all the experts here on this big complicated case.
Well, thank you, Professor Chow. This is a very interesting case. And I think we have quite a few experts in this field. And Professor Wei Lai is here because your center used a lot of Y90. Professor Wei?
Yeah, I'm here.
Yeah,
Yeah, you have a few of actually more than 100 in the patients. It's the E19, and actually it's very effective. The most of the patients with the huge some tumor size, and also E19 could be very effective to reduce the size, even in some almost disappearing. But actually, in the Professor Joe, and also have a very long experience for this one. So Professor, maybe give more comments for that. And also Professor visited our center and to introduce his experience.
I beg your pardon?
No, I just introduced and you visited our center.
Oh, okay. Sorry. Thanks. Yeah, right. Yeah. Welcome. Yeah. The other experts, anything to share about this? Of course, the tumor sizes were relatively low, for example, for the cholangio, and Dr. Shinai was in favor of RFA and microwave ablation. Right?
How about the dose? Pierre, you mentioned about you find some dose.
For this patient, we use a fairly high dose of about close to 200 grays. The late Professor Joseph Lau used 120 as a recommendation. And if you look at historical, in our center, we have treated patients for more than 10 years. We have about 700 patients, of which about 500 are HCC. So we have analyzed them. In the early years, based on Professor Lau's recommendation, most of the doses were quite low. And when we analyzed it, the response rate was also relatively low. After the SARA trial, it was people begin to realize that high dose is better. And of course, in the dosisphere, it was 200. But when we look at our data and we divide them into less than 150 and more than 150, the outcomes are quite significant. I think most of the centers today, especially the experienced centers, they have very good IR, very fine catheter, so they can take out the whole segment, the way they call radiation segmentectomy or radiation lobectomy. And the response has been very good with those. But the keyword is, of course, we need to have a very experienced IR as well to be able to put the catheters in, and very good nuclear medicine people to calculate the doses and so on. It's very much a team sport, isn't it? Yeah.
Well,
Can I ask a question to Professor Chow?
Sure.
So in Japan, we don't.
This patient has hepatitis B and HCC. And I was wondering if the year 6, it is a cholangio or it is a hepatocholangio, which is more common with hepatitis B.
Mhm.
And if it is a hepatocholangio, if not cholangio, would your approach be different?
So when we biopsied the tumor, the histology report came back as a cholangio, so it's histopathology as cholangio, and there was no mention of hepatocholangio. Of course, if it is a hepatocholangiocarcinoma, then the tumor will be even more aggressive. Their natural history is very poor. But this tumor was less than 2 cm, and when RFA was done for this tumor never seemed to appear again. Because the subsequent tumors were very different. In this tumor that was treated, the cholangiocarcinoma, with histology proven, the alpha fetoprotein was normal, the CA99 was normal, and the CEA was also normal. But when the HCC came back in year 7, the alpha fetoprotein went very high. So I think the cholangiocarcinoma that we treated was probably a different biology from the final tumor.
The
Which,
reason that the AFP became high, portal vein became
That's
thrombosed,
right,
and
that's
it
right,
became
thrombosis.
multifocal. It
That's
is
right.
for this reason only that I am thinking it might be a hepatocholangio rather than cholangio. Biopsy just might have picked up cholangio, but the way it is became aggressive after 6 years, I thought it may be hepatocholangio. This is my
Well,
thought.
Dr. Chow, may I comment on that too, Omata?
Yeah.
I think that's why I want to see the histology. Maybe this can be a mixed ones, cholangiocarcinoma and the hepatocellular carcinoma. But to address the issue and then get the final conclusion, we can do the sequencing to find out the driver mutations. If the FFPE is available, we can do that in our laboratories. So it just that may relate to the many of the questions how to treat, because if this is a consistently hepatocellular carcinoma origins, maybe that's quite different from the ones you are talking about. So that's the question I raised.
Well, the second lesion in segment 6, on imaging, you will not go for an HCC. If you
It's
follow,
so small.
yeah, 1.5 cm, there's no enhancement, no washout. So, which is why we rarely use histology to diagnose. But this is in this case because it was not classical. Biopsy was done. So this is a true cut biopsy, which is big core, and big core biopsy. The histopathology report came back. I'm sorry, I didn't have that slide to show you this time. But the histopathology report came back as the pathologists were convinced that it is cholangio, as opposed to HCC, and as opposed to mets from some other places. And at the time, the consideration was whether to resect that or not, or because it's quite small, it's 1.5 cm. Finally, the patient chose to have RFA. And I must say that from that side of the RFA, we don't seem to have a particular problem. It didn't recur. RFA worked very well. From our research, we have very extensive genomics research with HCC, and what we have found was that the original HCC and a subsequent HCC can have genomic signatures that are very, very different. There can be two different animals altogether. Looking back, of course, we can now go back and try to look at the genetic sequencing. But we have a lot of data to show that subsequent tumors from the molecular biology point of view is not necessarily the same as the first tumor. And they can behave quite differently. So the first tumor was by no means not aggressive. It has invaded the right hepatic vein, but it was a solitary tumor, responded extremely well to radiation and then to RFA. The second one was extremely rapid in progression. From one side, we very soon saw multiple sites. Also has a tendency to invade, but not the hepatic vein. I've got the feeling that the first one invaded the hepatic vein by virtue of its proximity to the vein. Whereas the second tumor is quite different. It is widespread portal vein thrombosis. Biology, which is different. So yeah, if we are maybe maybe I can go back and look at the genomic sequencing of these two.
Yeah. So the future meeting maybe should include the driver mutations information as well.
Except that this mutation information is not routine. It's not routine clinical service to do mutation. It's just that we have a research program. For example, the second one that we treated with lenvatinib and atezolizumab, there is no justification to do a biopsy for us because it is not actionable. If the patient were enrolled in one of our research programs, and we have a few, then there is a justification to do sequencing because otherwise it's not actionable and the patient have to pay for that, you see.
All right.
So I think in closing, I will just just bring back the points for discussion. The last couple of years, we've seen ablative radioembolization being used with very good results. And of course, I discussed the definition of what recurrence may be and whether the second tumor, is it really from the original tumor or it has a different biology altogether. Cholangiocarcinoma and HCC, the understanding today is that they have a common progenitor cell. And of course, I still maintain that if this patient had surgical resection the first time, he may not have had so many problems. Of course, Prof. Lau is also right. If we can convince someone to give him a liver, although he has got vascular invasion, he probably will be okay too. Yeah.
Well, this is it's a very interesting case, and thanks, Pierre, to share with us. And I hope that your continuous support to our APASL, the educational YouTube programs, virtual programs will benefit people. In the interest of time, I think we have to move on. And our next speakers will be Professor Omasi, and it will be about the management of portal hypertension in hepatocellular carcinoma. So may I have Professor Omasi from Turkey to show us the slides and to give us information and update on the management of portal hypertension in hepatocellular carcinoma.
Good afternoon, ladies and gentlemen. First, I would like to thank the organizing committee for inviting me to this very important seminar. Just I will try to prepare my slides. Okay, can you see my slides?
Yes.
Good.
Okay.
Very good.
Thank you very much.
Yes.
So my speaking for today, managing refractory ascites and in patients with hepatocellular carcinoma. I do not have any conflict of interest. For description, refractory ascites can be described by as unresponsiveness to high-dose diuretic treatments. So this means a body weight decline of 0.8 kilogram per day within 4 days, and natriuretic areas of less than 50 milliequivalent per day, or recurrence within 4 weeks of control ascites, increasing at least 1 grade, and even restricted of sodium. So high-dose diuretic treatment and therapeutic paracentesis also higher than 5 liters in one time. So development of clinically significant diuretic-induced complications or drug adverse reactions. Refractory ascites and one of the commonest complications of cirrhosis, and it's seen almost 15 to 20% of the patients, and 1 year mortality rate is high and can range from 20 to 50%. So is there any benefit of albumin infusion in patients with decompensated liver cirrhosis without large volume paracentesis? This is actually a very old topic, and already we know these results. However, as you see in this slide, long-term albumin infusion, 40 gram twice weekly for 2 weeks, and then 40 gram weekly for up to 18 months in patients with the compensated cirrhosis increases overall survival here. So it decreases the complication such as spontaneous bacterial peritonitis, hepatic encephalopathy, hepatorenal syndrome, something like this, and it corrects hyponatremia with serum concentration, and also hyperkalemia with serum potassium concentration compared to standard medical treatment, which is the combination of spironolactone plus furosemide. So is albumin infusion important after large volume paracentesis in patients with refractory ascites? This is also a very old topic. I think everyone knows these answers. So this is a randomized clinical study in the group of large volume paracentesis higher than 5 liter at one time plus IV albumin for 5 to 8 grams per liter. Ascites disappeared in 50 patients out of 52, and the plasma renin and aldosterone activity did not increase, and only one patient had renal impairment. In the large volume paracentesis group, also acid disappeared in 48 patients out of 53, and it was shown that increased plasma renin and aldosterone activity, 11 patients had renal impairment and hyponatremia. So this randomized comparative study shows us IV albumin infusion is important in evading occurrence of PCD, renal and electrolyte complications of activation, endogenous vasoactive systems in cirrhotics with ascites, and also development of such complications may impair survival in these patients. This meta-analysis includes 7 randomized controlled trials, including also 1,225 patients with refractory ascites, were approved for the study, which is comparing albumin versus dextran or gelatin or hydroxyl ethyl stock and the hypotonic cell line in patients undergoing large volume paracentesis. So this meta-analysis also provides evidence that albumin infusion reduces PCD, morbidity and mortality, besides that improved hyponatremia among patients with tense ascites undergoing large volume paracentesis as compared to alternative treatment, as you see here. PCD just favor of albumin, and also hyponatremia favor of the albumin. Is the combination of octreotide or midodrine superior to albumin in preventing recurrence of ascites after large volume paracentesis? This is also another topic. So this is a multicenter randomized double-blind placebo-controlled study to compare albumin with the vasoconstrictor combination of octreotide and midodrine in patients with refractory ascites who underwent large volume paracentesis. So the combination of midodrine or octreotide after large volume paracentesis is not superior to albumin in developing PCD. The combination of midodrine and octreotide after large volume paracentesis is not superior to albumin in delaying recurrence of ascites and preventing PCD in patients with cirrhosis. So tolvaptan is an oral selective vasopressin V2 receptor antagonist approved by for treating hypervolemic and euvolemic hyponatremia. So blockage of V2 receptors by tolvaptan prevents the insertion of aquaporin 2 water channels into the apical cell membrane of the collecting duct, and increasing free water excretion without significantly affecting urinary sodium and the potassium excretion. So maximum dose should be between 15 to 60 milligram. Maximum duration should be less than 30 days, and it's indicated in patients with grade 2 or 3 ascites with or without hepatocellular carcinoma. So tolvaptan response, is there any effect of tolvaptan on overall survival? This meta-analysis includes 9 studies and 736 patients with refractory ascites. It was shown that tolvaptan effectively decreases the body weight, as you see here, and also effectively decreases body weight and effectively increases serum sodium levels, and it increases overall survival too. So another tolvaptan study. In this study, clinical efficacy of tolvaptan in a dose of 15 milligram per day for 14 days was investigated in 40 patients with refractory ascites. Tolvaptan increases urine excretion, decreases the abdominal circumferences, decreases the edema in the lower extremities, and overall improvement in the hepatocellular carcinoma, hepatorenal syndrome, and hepatorenal syndrome, another one, type 1 and 2, I mean. So is there any contraindication for the paracentesis? There are several contraindications for the paracentesis. Uncooperative patients, abdominal skin infection at the proposed puncture sites, pregnancy, severe coagulopathy, and also severe bowel distension are contraindicated. So which treatment modalities is better for refractory ascites? Large volume paracentesis or TIPS? So this meta-analysis includes 5 randomized clinical trials and 336 patients with refractory ascites. As you see here in this slide, recurrence rate of ascites is lower in TIPS group, and the rate of encephalopathy is lower with the paracentesis group, and mortality rate is controversial in both groups. However, recent studies are favorable of TIPS regarding the survival. This meta-analysis includes 5 randomized clinical trials, again, and 336 patients refractory ascites, and compares TIPS versus large volume paracentesis for refractory ascites. It was shown that lower post-TIPS grade of ascites, lower post-TIPS levels of bilirubin, and also post-TIPS prothrombin time prolonged less than 6 seconds. So TIPS is safe and effective for ACC with symptomatic portal hypertension. So this procedure can relieve the symptoms, enable and bring survival benefit, which may come from the improved liver function from the reduced Child-Pugh stage. So is TIPS treatment safe and effective in patients with portal hypertension in hepatocellular carcinoma with portal vein tumor thrombosis? So the question is, and the answer is TIPS treatment was evaluated in 95 patients with HCC and portal vein tumor thrombosis. So the primary endpoints included success rate, procedural mortality, serious complications, decrease in portal systemic pressure gradient, and symptoms relief. And secondary endpoints included recurrence of portal hypertension, overall survival, adverse events related to treatments of hepatocellular carcinoma, and the quality of life measurement by Karnofsky Performance Status Scale. So success rate was 95.8%, mortality rate 1.1%. Serious complications related TIPS procedure occurred in only 2%. The symptoms of portal hypertension very well relieved. Variceal bleeding successfully controlled and terminated in 100% of the patients, with a recurrence rate of 39.2% in 12 months. Refractory ascites hydrothorax was controlled partially and completely in 92.9% of the patients during 1 month after TIPS, and with a recurrence rate of 19.9% in 12 months. So survival rate at 6, 12, 24, and 36 months was 75%, 52%, 26%, and 3.3% respectively. So as a conclusion, TIPS is very safe and efficacious treatment for symptomatic portal hypertension in HCC with portal venous tumor thrombosis cases. So this is another study which proves safety and efficacy of TIPS combined with palliative treatment in patients with hepatocellular carcinoma. In Group A, it comprised 217 patients with HCC and portal hypertension who underwent the TIPS procedure. After TIPS deployment, these patients received palliative treatment of HCC. So in Group B, comprised a cohort of 136 HCC patients with portal hypertension who did not undergo TIPS placement, and Group B received palliative therapy for HCC plus medical treatment for portal hypertension. In Group A, the primary technical success rate was 97% for TIPS placement. By comparison, the rate of hepatic encephalopathy in Group B was lower than that in Group A. So the mean survival time was 43.7 months in Group A, 31.8 months in Group B. The median survival time was 50 months in Group A and 33 months in Group B. So is de novo hepatocellular carcinoma increased after TIPS? This is also a very important question. A total of 1,338 consecutive liver cirrhosis patients were included in this retrospective study. The cumulative incidence rate of hepatocellular carcinoma at 1, 3, and 5 years did not increase in TIPS group compared to a non-TIPS group, as you see here. There are several factors associated negatively with post-TIPS survival. So 12 months mortality rate of TIPS changing between 26 to 33%, age higher than 65, low albumin levels, functional disability or sarcopenia, low GFR or high creatinine levels, high bilirubin levels, low platelet counts, and low serum levels, high MET score higher than 18 and child pulse score higher than 13. A small diameter coated stent of less than 10 millimeter is preferred to reduce the likelihood of post-TIPS complications, including hepatic encephalopathy. So is there any contraindication for the TIPS? Yes, these are the contraindications for TIPS. Age higher than 72, marked pulmonary arterial hypertension, creatinine levels higher than 3 milligram per deciliter, bilirubin levels higher than 6 milligram per deciliter, platelet levels less than 75,000, advanced liver disease, child put-through higher than 13, MELD score higher than 19, chronic significant or recurrent hepatic encephalopathy greater than 2, and uncontrollable coagulopathy cases, and elevated right or left heart pressures. These are the contraindications of TIPS. So if there are some contraindications in the patients with refractory ascites, then we should think about the liver transplantation of these patients. So if there is no any large volume paracentesis effective, or if TIPS are not effective, then we have just several options for those patients. One of them is just automated low flow ascites pump or alpha pump system versus large volume paracentesis for refractory ascites. So this is a multi-center randomized control study. Aim of the study is just in 7 centers, 6 months patient observation was conducted. Primary outcome was time to first large volume paracentesis. Secondary outcome included paracentesis requirement, safety, and health-related quality of life and survival. Nutrition, hemodynamics, and renal injury biomarkers were assessed in a sub-study at 3 months. So in this group, alpha pump system, just 29 patients approved, and the large volume paracentesis group, 31 patients approved. And finally, completed 6-month study in the first group, 17 patients, analyzed 27 patients, and excluded from analysis no any patients. So in the second group, completed 6-month study in 21 patients, analyzed 31 patients, excluded from analysis no any patients. So when you see these slides, alpha pump treatment group provided needs less large volume paracentesis over time compared to standard treatment of care. So alpha pump treatment is associated more acute kidney injury compared to standard of care. Alpha pump patients showed significantly improved chronic liver disease questionnaire scores compared with standard of care patients. P-value less than 0.05. So improvements in nutritional parameters were observed for hand group strength P 0.04, and the body mass index also statistically important, 0.001 in the subgroup. This meta-analysis includes 9 studies and 196 patients with refractory ascites. Effectiveness of alpha pump treatment were investigated in those patients with refractory ascites. Primary endpoints was absence of requirement of large volume paracentesis, occurrence of acute kidney injury, bacterial peritonitis, or urinary tract infection, and secondary endpoints was overall pump-related adverse events. So this meta-analysis demonstrated that most patients treated with automated low-flow ascites pump therapy do not require large volume paracentesis after pump insertion. Acute kidney injury occurs in 30% of patients, and creatinine levels increase by means of 23 micromole per liter after pump insertion. So bacterial peritonitis and urinary tract infection occurs in 27% and 20% of patients respectively. So are there any pump-related complications? Of course, there are many complications: peritoneal catheter-related dysfunctions, urinary bladder catheter-related dysfunctions, pump pocket complications, acute kidney injury, almost 30%, urinary infections, at least 20%, and spontaneous bacterial peritonitis, 27%, so on. So the Daniel shunt is implanted into peritoneal cavity through a left mini subcostal incision. The pump chamber located subcutaneously over the 15 or 12 rib. After aspiration of the ascites, a subcutaneous over the 12 and 11 and 12 rib. After aspiration of ascites, subcutaneous tunnel is performed and inserted into the subclavian vein, avoiding pinking the tube in the neck area. For the saphenoperitoneal shunt, the long saphenous vein is fully exposed and dissected. It is then cut distally, turned upward, and tunneled subcutaneously above the inguinal ligament. The peritoneum is exposed approximately 7 to 10 centimeters in the inguinal area, and at the end of 7 and 10 centimeters in the inguinal area, and to side anastomosis is performed between the saphenous vein and the peritoneum. Seven-step treatment protocol for the management of cirrhotic acid is applied in Japan. So first step was supportive treatment. Second step, sodium restriction, albumin and albumin maintenance. Third, spironolactone, and the fourth step, furosemide, adding the furosemide. Step 5, adding the tolvaptan. Step 6, large volume paracentesis and CART. So this means cell-free concentrated ascites reinfusion of the treatment. This is usually using in Japan and some European countries. Also, step 7, just peritoneal venous shunt or TIPS, and then finally liver transplantation. So this is step 7. What guidelines say about the large refractory ascites? So in step 7, the treatment of refractory ascites, generally Japanese Society of Gastroenterology or Japanese Society of Hepatology published in 2020. So recommended peritoneovenous shunt or TIPS or liver transplantation. PVC should be considered for patients who are resistant to large volume paracentesis or CAR. TIPS is currently not covered by insurance in Japan, and in the above treatments are ineffective, then liver transplantation should be considered. In APASL was published 2018, patients with refractory ascites should be evaluated for liver transplantation. Patients with RA or recurrent ascites or those for whom paracentesis is ineffective should be evaluated for TIPS. So TIPS is recommended in patients with recurrent ascites in those with RA. ASLD was published 2021, and TIPS in well-selected patients with refractory ascites has been shown to be better than repeated large volume paracentesis in the control of ascites. Liver transplantation should be considered in patients with refractory ascites, particularly those with refractory ascites unresponsive to TIPS or with liver dysfunction that precludes TIPS. Italian consensus was published 2021. Patients with refractory ascites, recurrent ascites, contraindications to TIPS placement are heart failure, severe pulmonary hypertension, uncontrolled sepsis, or other contraindication to TIPS, severe liver failure, CTP higher than 11, INR higher than 2, total bilirubin higher than 5 milligram, severe intrinsic renal failure, serum creatinine levels higher than 3 milligram per deciliter, current persistent overhepatic encephalopathy. So, Mr. Chairman, ladies and gentlemen, as a conclusions, diuretics should not be continued in patients with refractory ascites who do not excrete higher than 30 millimole per day of sodium under diuretic treatment. Repeated large volume paracentesis plus albumin 8 grams per liter of ascites removed are recommended as first-line treatment for refractory ascites. If serum renin-angiotensin activity and aldosterone activity are increased, or if hyponatremia occurs, then in those patients, tolvaptan can be added on large volume paracentesis plus albumin infusion treatment. Patients with refractory or recurrent ascites or those for whom paracentesis is ineffective should be evaluated for TIPS insertion. TIPS controlled ascites better than large volume paracentesis, and it improves survival, but it is followed by a greater incidence of encephalopathy. At present, the addition of clonidine or midodrine to diuretic treatment cannot be recommended. Alpha pump or CART systems can be suggested in patients who do not respond or contraindication to TIPS treatment. So liver transplantation should be recommended in patients who do not respond to TIPS treatment. So I'd like to thank you very much for your patience, and just I would like to invite you to Istanbul in 2026 for APASL annual meeting. Thank you very much.
Thank you, Professor Ormesi. It is very interesting topic and is delightful. And at the end, we are going to close the ALCA 14th edition. So this time, for the first time, complications of cirrhosis, that is advanced cirrhosis with SCC. So in subsequent episodes, we will go by complications to be managed in patients of advanced cirrhosis with SCC. So at the outside, I thanks Professor Lai Wai for being supportive and throughout the whole session, Professor Sena and Professor Sarin, as well as Professor Omada to be there always and along with all Professor Deepti and Professor Abbas and the whole team from the ALCAP. And with this, I want to conclude the session. Thank you. Hope to go. Bye.
You.
Thank you. This is Dr. Omata. Thank you for the AHOC. 4,000 cases we are able to register. Thank you, VLI.
Thank
Thank
you,
you.
Professor Mata.
4,000
Thank
cases
you very
in
much.
a year.
Okay. Bye.
Bye-bye.
Bye.
Bye-bye.
All right, Oromechi, thank you.
You are welcome,
Thank you.
Omata Sensei.
Oromechi, good.
Thank you very much.
Thank you.
Gyojiro, thank you. Yeah, I'm gonna have a dinner now.
Okay.
Have
Bon
good day, like,
appetit.
too late. Too late. Professor
All
Mata.
right.
All
Okay.
right. Okay.
Dr. Chao, thank you very
Thank you.
much. Yes.